I'm going to start with some of the questions and open it up to some of the mics. Dr. Nakakura might take the first question. Is lunch provided on Sunday, or should we bring a sandwich? Dr. Nakakura missed lunch, so he had to bring a sandwich. How many tumor cells in a 1 cubic centimeter tumor? I had to Google that, so I've got that for you in case. It's 1 billion cells in a cubic centimeter of tumor. And something that I think Carrie touched on is, what do I tell my doctor if I want to find out more about NETs? Sort of the implication is your doctor doesn't really know that much about NETs. And I will tell you that last year we had a session devoted to exactly that. We had a speaker that addressed the question of how do you talk to your doctor? And how do you get the information from your doctor that you need, and what do you do when you're not getting that information? So maybe I could just start with that as a starter, which is how do I talk to my doctor, or how do I get more out of my doctor? Nicole, what do you tell patients when you have an angry patient that just saw me and came away clueless, and she comes in to see you? What do you tell them? How do you advise them?
That's never happened. Does that work?
Yeah.
So this is a very common thing that as a nurse practitioner I've encountered, and I think the first thing is to really validate for patients that this does happen. There's frequently miscommunication. I think somebody on the panel spoke to this already, but recognizing the roles of the different medical providers and what you're going to get out of them. Your doctor may be an expert in one area, but it may really be somebody else on the team, like a social worker or an outside acupuncturist or somebody else who's going to provide the other things you need. And so I think having realistic expectations and knowing what everybody's good at. Nobody's going to be good at everything. And so that's often what I tell people is, if you asked a Western medical doctor about taking herbs and you're really upset that they didn't know anything about it, that's just not their area of expertise. So I do a lot of expectation setting and helping people understand that. I think having lists of questions going into your doctor so that you make sure you really get your questions asked, and asking the doctor to slow down, or anybody on the team to slow down so that you can take notes if you don't understand, like not being shy to do that.
I think the list of questions is a really important one, particularly when you see people only intermittently. And if you can get the list of questions to them in advance, that's sometimes even better. But if I come in and I have 10 pages of questions, make sure you prioritize. Which questions do you need answered right then? I think that's an issue of taking charge. Eric, there's a question about what is carcinoid crisis, and should patients be worried about that when they go in for procedures or operations, and what sort of precautions do you take in dealing with that?
Yeah, that's a very good question. I think the key issue about that is prevention. You all know you have carcinoid, that different triggers can set it off. Similar, like if you undergo anesthesia or a painful procedure, like let's say a biopsy, those are all things that could set off the release of hormones from your tumor. There's not great, evidence about preventing this, and I know people like Rod probably are looking at it, but certainly most of us take a cautious approach of making sure that before you get anesthesia, before you get a procedure, that you get put on an Octreotide bolus and then a drip, just to prevent it. I mean, you don't want to find out after the fact, is my sense. So it's a very rare thing, but when we've seen it, it's pretty profound, and you don't want to be reacting to it. You want to prevent it.
And my sincere apologies. Usually when we have this, we've given Eric already an opportunity to speak today, but we didn't today. So Eric Nakakura is a surgeon at UCSF and specializes in neuroendocrine tumors. And you heard about him earlier because Ron gave him some credit for some of the research that he's done with Caring for Carcinoid Foundation grants. So thank you for coming, Eric. And similarly for Andre Aguero is a nuclear medicine specialist who has done tremendous things in getting the Gallium Scan out. And Andre, I'm going to challenge you with a couple of questions, and they're questions that you're happy to ask a fellow panelist if you need some help. But here's from one of our patients. I just had a Gallium scan, and it was negative. So when do I need my next one?
All right, so first of all, thank you for the invitation to be here. It's really great to see familiar faces and to meet new people. It's a great meeting. I'm not only saying this to buy time to formulate the answer to the question, I really mean it. So when is the next time for a repeat scan? The true and honest answer is nobody really knows. People who say that they know when the next scan should be done probably are basing that on some personal experience, but nobody has done a well-designed study to do repeated studies at random intervals and then see which one is the useful. We learned from other radiopharmaceuticals used in nuclear medicine that for most cancers, there's no clear cutoff as to when surveillance scan should be done. Probably when there's a biomarker that starts going up or when you have symptoms. But your oncologist, your treating physician will know best when it's the time to have a scan done. And I hope that perhaps Emily or Pam or
maybe
George.
actually, I'm going to challenge the lovely woman from UCSF on your left. Emily, would you mind talking about scan frequency? Because many of our questions here, well, what scans should I get and how often? And should I worry about cumulative radiation? So it's a common problem, and we have to deal with this every day. What's your answer to that?
It's a great question, and one for which we don't have a great answer yet. I would say it depends a lot, in my view, on the goal of the scan. The current guidelines, which are sort of empirically driven, we don't have good data to support them, but at this current time, generally after resection of disease, I think many of us will do scans, potentially on the order of about annually for up to 10 years. This would be in people who don't have any remaining disease, who have just undergone resection of their disease. That's very different than when you're actually monitoring a patient for tumor progression who has known disease in place. And there again, it really, for me, it's very individualized. I think if there's something on a scan that I'm worried about, I might do a follow-up scan in 4 to 6 months. On the other hand, there are patients who seem to have very stable disease and whom I might do a scan only annually. And in terms of the type of scan, it really varies. I mean, we have many patients who prefer and can do MRI scans. Other patients prefer to do CT scans, and I think the optimal scan is unknown. And now, of course, we're starting to have things like the Gallium-68 Dotatok PET CT available, not widely and not routinely, but coming down the pipeline. So again, where that fits in relative to these other imaging techniques and how often to do them, I think is unknown right now.
But I also think that patients tend to get over-worried about the amount of radiation dose they're getting from imaging. If you look at a Gallium-68 scan, that's the equivalent of flying from San Francisco to New York. You're exposed to the same amount of radiation in the passenger cabin. Octreotide scan's about a round trip from New York. So when you need it for monitoring, it seems well worth it because we get a lot more exposures to other things when we're under treatment. And if we do have cancer, it's probably a somewhat overblown worry about I'm getting too much radiation from surveillance scans when you already know we have some disease.
Yeah, and I would like to address this briefly in saying that, we know that we can be hit by a car when we cross the street, we still cross the street. So similarly for radiation exposure, I think that the amount of radiation exposure for some of these scans, if done appropriately, it's not a matter that will produce long-term issues for the health of our patients. Keep in mind that all the healthcare professionals that work in radiology and nuclear medicine are allowed to receive each year a log order, so at least 10 times more radiation than what you get from a couple of these scans. So we're allowed to have that every year for our professional life. So if that was unsafe, that will not be allowed. So I think that as long as it's medically indicated, these scans are safe to be done in patients.
So I've got another sort of imaging question that maybe Pam can comment on. Bone metastases, when do we treat those and with what? I felt well, my prior CT scans all looked fine, and I got one of these gallium scans and there was light up in my bones. Now what do I do?
That's a good question. I think for many patients we're learning how to interpret gallium scans. I think gallium scans in particular are more sensitive, meaning we often will find smaller sites of disease. And I think that for the patients that we're finding out they may have more sites of disease or bony disease on the gallium scans, it doesn't necessarily mean that it's new. And I think that if they're asymptomatic, it also doesn't necessarily mean that it needs to get treated. I think for patients who are already getting systemic therapy, we would think that that systemic therapy would also help manage the bony sites of disease. But for some patients, they may have pain at sites of bony disease, and we have other tools to treat painful bony sites, such as radiation. There are some other evolving tools, such as ultrasound-directed treatments, but we do have ways of treating symptoms from bony disease, and we also have other ways of helping to strengthen the bone for patients with bony metastatic disease. There are medicines that can help do that. I don't know if Emily has other comments.
I agree.
I think sometimes when you get apples and oranges for scans, you have to prepare yourself for different answers or different results. And finding a new bone met on a gallium scan doesn't mean that that's a new metastasis. You may have had that from the start. So you have to be careful as to how you interpret these new findings when you get a different scan. I've had this question 3 times now, so I'm going to answer it myself. If I have a grade 1 tumor, when does it become grade 2, then grade 3? And fortunately, that very, very rarely happens. In fact, I've never been convinced that I've ever seen it happen. I hear about it in the literature, but I think that's got to be exceptionally rare. So generally speaking, if you have a well-differentiated tumor, it remains well-differentiated. It doesn't all of a sudden take off and become a more aggressive tumor. Emily, do you feel the same way? I mean, feel free to disagree.
Yeah, I totally agree. I think generally speaking, that's true. I think the only take-home point I would make is that if something doesn't fit, if the biology doesn't fit with the biopsy, then that's something that's a situation in which we might actually consider repeat biopsy.
Yeah, exactly.
I think it's very, very rare, but sometimes these biopsies can be difficult to interpret. They might be really small. Maybe it was done at another center many, many years ago and isn't even available for review. And so I think if the pace of disease doesn't fit, if something's just not feeling right, then I think rebiopsy is worth considering.
And then a similar misconception that I didn't clear up in my sort of net basics in the morning is if I have a midgut carcinoid, does it ever become a lung carcinoid or a pancreas carcinoid? No. Now, there are people who have genetic predispositions where they may get more than one type of neuroendocrine tumor, but generally speaking, if you have one type of carcinoid, that's the one you're stuck with. And it may spread to other organs, so it doesn't become a liver cancer. It's still the same tumor from the original midgut that's now in the liver. But the discussions that you heard earlier with the bronchial carcinoids and the pancreatic neuroendocrine tumors, those are defined as tumors that started in that area and grew in that area. They may spread to other organs, but they don't change to a different type of tumor. Eric, there's a lot of questions here about carcinoid syndrome. And one of the questions is, when does a surgeon take care of carcinoid syndrome?
That's the key question about when should surgery be done, at all, is always comes up. And I think the important thing that you've heard mentioned over and over again is you got to go to a place where there's a group of people all discussing it. Because if you go to an isolated person out in the community, let's say you go to an interventional radiologist and say, should I get TACE? Of course they're going to do TACE, because that's what they do. If you go to a surgeon in the community and say, should I get surgery? Of course you'll get ablation or surgery, because that's what they do. But if you come to a center where you have a whole group of people managing disease, we all talk about it and talk about all the options, including certainly non-surgical therapy. So, it's a long answer to say what we do all the time, which is we discuss every patient, and each patient gets an individual answer. There is no one-size-fits-all answer for that question.
I have 2 questions that specifically ask for Dr. Bergsland's comments. And so one is the difference between lanreotide and octreotide, and another question related to that is, I have heard octreotide has a higher incidence of being administered incorrectly. Is it true that lanreotide has less risk of being administered incorrectly, and what are the differences between the 2?
Well, I would say that there are a couple of differences that should be discussed. One is that they're given in slightly different ways. Octreotide is given as an intramuscular dose, whereas lanreotide is typically given as a deep sub-Q. The pharmacokinetics are also somewhat different. Another thing to know about is that lanreotide comes in a depot form. There isn't a short-acting version, but there's also no need for a short-acting version. It was, at least the way it has been developed is just to go to an immediate long-acting injection. The flip side is just to remember that Lanreotide currently is approved in the United States for treatment of tumor progression. Octreotide, its current FDA approval is for carcinoid syndrome. I think many of us believe that they're very similar drugs, and both, there's certainly data to support both of them having anti-tumor activity and both of them having an ability to treat tumor symptoms. In terms of the being injected improperly, I don't think there's ever been, that I know of, any sort of head-to-head question or study addressing this. Certainly there are reports of octreotides anecdotally from patients, as well as there's been some limited studies done in this area suggesting that it can be tricky to get it properly administered IM. Again, I don't know whether there have been any studies planned or ongoing in terms of Lanreotide. Remember, this is a new drug for us in the United States, at least in terms of carcinoid. It's been approved for acromegaly, but in our patients, we're learning from them in terms of how well the injection goes and whether it's given properly. I don't know if anyone else wants to weigh in on that.
Here's a question for Dr. Kuntz. There are lots of trials going on to extend life or potentially cure neuroendocrine tumors. Are there any studies to detect neuroendocrine tumors in early onset? And you can call a helpline from Andre or Eric if you like.
I may call a friend. So I think that's a great question, and really one that applies to all cancers, is around early detection. I think the challenge with neuroendocrine tumors, it's a fairly new field in terms of research. And I think it's really just been in the last decade that we've really been able to do high quality research. So what that means is that even the epidemiology, or meaning who gets neuroendocrine tumors and why, is still relatively new. And so we're trying to learn more about that, and as we do, hopefully some of our newer diagnostic tools will improve diagnoses. I think George had a slide up earlier about the incidence increasing for neuroendocrine tumors, but I think much of that increased incidence is because our diagnostic tools have gotten better. We diagnose many of the GI nets on endoscopies. Our scans are quite a bit better in terms of improved resolution, so we're incidentally finding a lot of nets. I may turn it over to Andre, but I think certainly some of the Gallium-68 imaging, I think that's more sensitive as we're learning more about how to use that tool. I'm hopeful, I don't know if it will be a screening tool, but we certainly may diagnose at earlier stages.
So as far as Gallium Scan goes, as of now, there is data to suggest that in the absence of a diagnosis of neuroendocrine tumor, so just because someone has a biomarker that's elevated but no tissue diagnosis, the performance of the scan is not as good as when you have a diagnosis and you want to see how extensive disease is. So I wouldn't advocate for it as a screening. I think that what's needed, and there's multiple ways of arriving at this, is to identify those neuroendocrine tumors that are likely to behave more aggressively versus those that are more likely to be indolent, because you don't want to have the example of what happened with other cancer, where just by finding disease, because the tool is available as a screening in the doctor's office, a lot of people end up having surgery instead of, or other kind of treatment, instead of actually living with that indolent disease that otherwise may not have done anything bad to them. That's just my take on it.
I'm going to ask this question of one of my favorite Chardonnay buddies, and I hope that they don't all jump up and say, that's me. Carrie, other than minor, should no alcohol be consumed if someone has liver mets with carcinoid?
Well.
I'd like the letter.
You get that one, not me.
When I was diagnosed, I asked.
That's not a Flushing episode, by the way.
When I was diagnosed, I was worried about that, and I asked the doctors, and I said, is this going to make a difference if I have any alcohol? Because I do have carcinoid syndrome, but it is not one of my triggers. So I said, if it's going to make a difference of me living, 20 more years, or if it's going to really affect me and I'm only going to live for 5 more years. And they said that there were no studies done that proved that. So I drink.
So the answer is okay. The answer is okay,
As far as
everybody.
I know.
Now there can be, just to be fair, there can be an issue if the liver is involved enough that the liver function is not very good. Then you might want to think back about stopping anything that could impair liver function. That would include things like Tylenol and alcohol. But if your liver function is fine, then there's nothing about liver metastases that mean that you cannot enjoy a glass of wine, always in moderation, right, Carrie?
Yeah.
I'm going to say two comment slides because two comments here that were not questions, but just in case we didn't inform the audience as clearly as we might have. One says PRT is available in Europe, and we were talking about the clinical trial that's going on here. So yes, you're right, PRT is available, in fact, a standard treatment in Europe, and some of our patients have gone to Europe just specifically for that. Secondly, Lanreotide is approved in the US for GEB-NETs, for neuroendocrine tumors, and that's true. I think what Emily was saying was that it's not approved for the syndrome, which is also true. It's not approved for managing the syndrome, but it is approved for it's slowing the growth of tumors. That's not to say that you can't take it if you have the syndrome, but that's just sort of technical talk. I have another one, which is, can you comment on exercise in neuroendocrine, both moderate and more extreme, like marathons, and might it ever accelerate the disease? I don't know if Angela or Nicole?
As I said, can you hear me? A lot of the research with exercise and cancer has been done in the breast cancer population. Breast cancer is obviously a more common cancer than neuroendocrine tumours. So we do know that that exercise is very important for overall well-being, especially when you have cancer. I don't know of any research that says that doing extreme exercise actually stimulates tumour growth. That's kind of what the question was?
Yeah. Is there any concern about doing that?
So no, as long as you're functioning okay in the rest of your life, you're able to maintain weight, because that's one of the things with exercise. It's often a fine balance between expending that energy, especially if you have trouble gaining weight or maintaining weight. You don't want to use all of that energy and those calories on exercise. So that can be sort of the balancing act. But in general, I think exercising to what you can tolerate is probably the best advice.
I have another one for Andre here, and this is it's sort of an unfair question, but I'm going to ask it anyway. But before I ask it, I want to thank Andre on behalf of everyone in the audience who has had interest in gallium scans. That it was an enormous amount of work to open up a gallium scan. You've heard that many institutions have tried to open it. It's just a labor of love. He spent I don't know how many man-hours, man-days trying to get this through with personal attention, and managed to get Stanford to pay for the generator, managed to get Stanford to, he does the scans for free, but we had to charge for their germanium to create the gallium-68. And that in itself took us through the FDA, through Medicare, and through Stanford finances, and every once in a while we hit another glitch. Insurance doesn't always cover that, so the question, getting back to the question now, because we're all grateful to you for having put this through and as much work as it took. Why aren't all clinical trials free? And we might address that separately, and then specifically it asks, why isn't the gallium-68 free, since it's called a clinical trial?
So it is a fair question. In general, whenever you run a clinical trial, you have a sponsor. And that sponsor can be the NIH, so the government, or that sponsor can be a company who has an interest in bringing that new drug to the market. Unfortunately, in the case of gallium, doratate, doratalk, doranok, whatever is chosen to be taken, neither of those options are available, because scientifically, NIH, the government, will only fund things that are very novel. And as you know, none of these are novel. They're novel for us in the US, but they've been done in thousands of patients worldwide. So there's no novelty to it for the government to fund. Because this has been done for quite a while, more than a decade, there's no IP, there's no patent available for it. So there's no company that is willing to put the money into bringing it to market. So therefore, someone has to pay for it. We are able to to do these scans at Stanford through a cost recovery mechanism. So what it means, it's we only charging what it costs, and we audit it by an external non-Stanford affiliated accountant who looks at all the invoices, all the costs that are needed to produce it, and that's all that we charge. So really it's a surviving mod. It's done as a trial because it's not FDA approved. Otherwise, there's really nothing, in my opinion, that means that this is experimental after thousands of patients have been imaged with it. So we have to navigate all of these regulatory issues. We're able to do it, but we have to charge. Otherwise, we would not be able to offer it. We're unable to charge Medicare Medical because that's one of the rules of this cost recovery mechanism. I would say that about 3/4 of insurance companies are paying for the cost of the test, and we're fortunate, and I want to acknowledge the support from the Carcinoid Cancer Foundation and the generous anonymous donor who provided funding so that for those patients who don't have medical insurance other than Medicare, we're able to cover some of the costs from that gift. Otherwise, the truth is that the Department of Radiology is covering the cost, so they're taking a loss when insurance doesn't pay for it. How long can we be able to do that? I don't know for sure, but we'll try to stretch it as much as possible, and hopefully one day will be FDA approved. So sorry for the long answer, but that's the reality of it.
Okay, and I think what may be the last question, depending on how quick Eric is here. I have both liver metastasis and I have cysts in my liver. Does that preclude a surgery? And how do I know that all the liver metastases are carcinoid, not some other type of cancer?
That's a very good question. I think, regarding the cysts, most of us, or many patients have cysts, and it's a very common finding. So if they're clearly characteristic cysts on imaging, I wouldn't worry about it. It doesn't affect your liver function unless very rarely, when they're extensive, it can. But most patients, it's inconsequential. Regarding the, how do you know if all the masses in your liver are liver metastases? Well, that's why we have good radiologists like Andre and other people that help weigh in about what they think things look like. But I think if we know you have carcinoid disease and you have liver lesions and they all look very similar, then I think that's reasonable to assume. Obviously there's some instances where we don't know if you have, let's say, a small intestinal neuroendocrine tumor and you have a liver lesion and you've never been diagnosed with metastasis. The question is it a hemangioma, which is a benign blood vessel tumor, or is it a metastasis? Again, sometimes it's very difficult to tell, and sometimes we may even get a biopsy.
And that might be a role for getting Gallium scanned, because if it lights up, it's probably a neuroendocrine tumor, or it might be a role to getting an MRI if the liver is fatty and you couldn't see it on a CT scan. So we consult with radiologists routinely, and that's why this is, as has been discussed, a multidisciplinary disease. So I can ask a radiologist, what's the best imaging test to get to answer that particular question? I will actually ask one more question, and it's directed sort of at Emily and Pam. And I think I have 5 different questions related to the same thing. They all relate about biomarkers. So what chromogranin A, what biomarkers do you get routinely on patients is one of the questions. And the second is, when do I get worried that the marker is so high that I need to do something? And let's start with chromogranin A, pancreatic polypeptide, 5-HIAA, the usual ones, and then we'll get a little bit more complicated. Emily, you want to take first jab at it since you...
Yeah, it definitely depends on the situation. I would say certainly somebody who has symptoms, you're going to certainly be driven to do the appropriate test for that symptom. So somebody who's thought to have a small bowel carcinoid with flushing and diarrhea, you're obviously going to check a urine 5-HIAA. I do a urine 5-HIAA. There's also a plasma test available. I tend to like it at baseline, even somebody without symptoms, just for a baseline, so I understand. It's very interesting to me that while I think it's generally true, the higher the 5-HIAA, the greater the symptoms, but I've been struck by the variability in how there are patients with a high 5-HIAA and very few symptoms, and then there are people with a lower value that are, above normal, but still not hugely elevated, who are very symptomatic. But so I'll do 5-HIAA. I tend to do chromogranin, ideally in somebody who's fasting and off a PPI. Usually I do a week if the patient can do that. For pancreatic neuroendocrine tumors, it really hinges on what the symptoms are, and there are some very classic syndromes that'll help me with that. The only other biomarker that I do regularly is a pathologic one, which would be Ki-67, and I ask the pathologist to make sure that's checked. But none of this actually really helps you to choose a therapy necessarily or predict whether a therapy is going to work. I do them to establish a baseline, and then I will certainly, for the blood and urine markers, I'll do them periodically when I'm, for example, re-imaging a patient. And I consider them in the context of the imaging results, the patient's symptoms, and then the biomarkers, basically. And that collectively is how I decide whether or not to change therapy.
So to put you just on the spot a little bit, we have 2 questions that asked, well, what about the NET test? Should I get it?
Oh, you're making me answer that one? So the NET test is a commercially available test that I actually don't use. I think that that's, and honestly, I'm going to claim a little bit of ignorance on it, but it's the one that's based out of
Yale.
Yale, yeah. Pardon? Yeah.
Based out of someone who lives there.
Rin lab.
Yes. So I'll just comment on markers in general, but I think that there are some that are less well studied, so including the NET test, including the plasma 5-HI that I think has not been rigorously studied in a prospective way. And I think that, we're really looking for better biomarkers, both in terms of ways we can predict responses to treatment and help also predict a patient's disease course. And I think that unless they've been studied along with sort of prospective clinical trials, I think we just honestly don't know how to use them that well. And I think that still holds true for some of our existing markers like chromogram. And so I totally agree with Emily. It's something we tailor to the individual patient. It's not, I don't use the chromogram alone to make a decision. I'm totally in agreement that I use that in coordination with others. So I dodged your question a little bit, George, but I'm actually not even using the NET test.
Not surprisingly, that's what I do too. I do whatever you tell me. Eric.
Well, one thing I think is important that you get the test done at the same lab because, every lab has a different cutoff for the chromogranin A, for example. Another example is I had a patient that had a Whipple for pancreatic neuroendocrine tumor from India, went back to India, got the chromogranin A, it came back elevated like 100 times normal, came here, got it done at UCSF as normal. So again, it just tells you
So
that.
if you want to feel good, go have your labs done at UCSF.
Right. But there's another study recently, like gastrin levels. You get a slip back that says your gastrin level is elevated, and you're like, what does that mean? There's a study that came out of the NIH where they look at 12 labs that measure gastrin levels, and only 7 out of the 12 were at labs that had no QI. They had no verification that their assay even worked. They're just basically charging you for a number that you got back. And so it's very important that when you get these values back, that it's at a reputable lab that has a track record for producing results that you can believe. So don't just go to any lab, especially for gastrin. Gastrin's a very funny lab. So if anybody's had a high gastrin, get it checked again at a dependable place.
So I'll close with one question here. What is, and somebody's been Googling or getting on the CFCF website, I assume, or somebody paid a lot of attention to Ron when he was up talking this morning. What is co-delivery of doxorubicin and siRNA using octreotide conjugated gold nanorods for targeted NET therapy, and where do I get it? So that's actually a research study that Herb Chen is doing at the University of Wisconsin, and it's research that currently is limited to mice. So if you want to get it, you have to grow some fur and a tail, and you too can be a candidate for that clinical trial. So I want to thank Pam and Ron for putting this together, and thank all of you for your undivided attention. We'll just assume that. And Pam and Ron, if you have some closing remarks.
Yeah. Thanks. Well, I want to thank all of the speakers who've spent their time today with us, and thank you to the Caring for Carcinoid Foundation for co-sponsoring this with us. And thank you to all of you. It's truly an honor to put on this symposium that we've now done a few years, and I come away from this conference just feeling very hopeful and appreciative to be able to do what we do. So I thank all of you.
And many thanks to Pam and George and all these speakers, especially and including the ones who we had to say we know you want to give a 30-minute talk. You got 10 minutes. Can you help us? Because we really wanted to impart to you, there's so much diversity of resources and expertise out there that can help you on your journeys. And so we will be posting all of these videos. We can get the lists of books that people had suggested to you. Please fill out our evaluation forms. That'll go not only to all of you here, but for those of you who are still with us. I know our European friends hit midnight a couple hours ago, and they're probably asleep now. But we'd like your feedback in terms of what worked best for you. We wanted to empower you with information. We wanted to give you strategies. We wanted to connect you to resources. And most importantly, we wanted you to leave here with confidence and hope that you're not alone in your journey. And there are many things that we can do to help you on your way. Before you leave, come join us at the poster session where you can learn about the Inca survey and much of the wonderful work that's being done here at Stanford. And let us know what you think. And George, any last comment?
Well, I didn't get a chance to answer all the questions. I'm willing to hang out here for a little bit, so please just go ahead and ask them if I didn't get a chance to answer your cards.
And again, thank you all for very much for joining us.